Welcome. Today we're diving into a specific type of heart disease known as transthyretin amyloid cardiomyopathy, or ATTR-CM. This condition, while often underdiagnosed, can significantly impact heart function and overall health. We'll explore its causes, effects, diagnosis, and treatment options to better understand this complex disease. ATTR-CM occurs when a protein called transthyretin, or TTR, misfolds and clumps together, forming amyloid fibrils. These fibrils deposit in the heart muscle, making it stiff and unable to pump blood effectively. There are two main ways this can happen. The first is through a genetic mutation, leading to hereditary or variant ATTR-CM, often abbreviated as ATTR. The second is a non-hereditary form, known as wild-type ATTR-CM, or H is linked to aging and is not caused by an inherited gene mutation. Both types ultimately lead to the same problem: amyloid deposits in the heart. The core issue in ATTR-CM is the accumulation of amyloid fibrils in the heart. These deposits infiltrate the myocardium, the heart muscle tissue. This infiltration thickens the heart walls, particularly the ventricles, making them stiff and less compliant. This stiffness hinders the heart's ability to relax and fill with blood between beats, leading to diastolic dysfunction. Over time, the impaired filling and pumping action of the heart results in heart failure. The amyloid deposits can also affect the electrical conduction system of the heart, leading to arrhythmias such as atrial fibrillation or heart block. ATTR-CM is increasingly recognized as an important cause of heart failure, particularly in older adults. While the exact prevalence is still being studied, it's estimated that a significant percentage of patients with heart failure with preserved ejection fraction, or HbF, may actually have ATTR-CM. ATTR is the more common form, typically affecting individuals over the age of 65. The hereditary form, is less common overall, but its prevalence varies depending on geographical region and ethnicity, as certain gene mutations are more prevalent in specific populations. The signs and symptoms of ATTR-CM can be varied and often mimic other heart conditions, making diagnosis challenging. Common symptoms include shortness of breath, especially with exertion fatigue, swelling in the legs and ankles, and irregular heartbeat or palpitations. Patients may also experience symptoms unrelated to the heart, such as carpal tunnel syndrome, spinal stenosis, or biceps tendon rupture, which can occur years before cardiac symptoms develop. These seemingly unrelated issues can provide important clues to the diagnosis. Diagnosing ATTR-CM typically involves a combination of tests. An electrocardiogram, or ECG, can show abnormalities in the heart's electrical activity. An echocardiogram, or ultrasound of the heart, can reveal thickening of the heart walls and impaired diastolic function. Cardiac magnetic resonance imaging, or MRI, can provide more detailed images of the heart and help identify amyloid deposits. A bone scan using a radioactive tracer is often used to detect ATTR amyloid deposits in the heart. If positive and there are no signs of multiple myeloma, it is usually diagnostic of ATTR-CM. If the bone scan is not diagnostic, a heart biopsy may be necessary to confirm the diagnosis and determine the type of amyloid present. Genetic testing is crucial to differentiate between ATTR and ATTR-V. As we discussed earlier, ATTR-CM is broadly classified into two main types: wild type, or ATTR, and variant, or ATTR-V. AT is the non-hereditary form associated with aging. ATTR-V, on the other hand, is caused by a genetic mutation in the TTR gene that's passed down through families. Within ATTR-V, there are numerous different mutations, each potentially associated with varying symptoms and age of onset. Treatment for ATTR-CM focuses on managing symptoms and slowing disease progression. Traditionally, treatments included medications for heart failure, such as diuretics to reduce fluid buildup and beta blockers or calcium channel blockers to control heart rate and blood pressure. However, newer therapies specifically target the TTR protein. TTR stabilizers such as tafamidis work by preventing the TTR protein from misfolding and forming amyloid fibrils. Inotersen and patisiran are TTR silencers that reduce the production of TTR protein in the liver. In some cases, a heart transplant may be considered for patients with advanced disease. Supportive care, including lifestyle modifications like a low-sodium diet and regular exercise, is also essential. Currently, there are no proven methods to prevent ATTR-CM, as it's associated with aging and not directly preventable. However, maintaining a healthy lifestyle, including a balanced diet and regular exercise, may help support overall cardiovascular health. For individuals with a family history of ATTR-CM, genetic counseling and testing can help determine their risk of inheriting the condition. Early detection and management of symptoms are crucial in slowing disease progression. The prognosis for ATTR-CM varies depending on the type of amyloidosis, the severity of cardiac involvement, and the individual's overall health. Untreated ATTR-CM can lead to progressive heart failure and death. However, with early diagnosis and treatment, Particularly with newer TTR-targeting therapies, the prognosis has significantly improved. Recent research is focused on developing even more effective therapies, including gene editing techniques to correct the underlying genetic mutations in ATTR-CM. Ongoing clinical trials are exploring new approaches to diagnose ATTR-CM earlier and to better understand the disease's natural history. This ongoing research offers hope for further advancements in the management of this challenging condition.